We move to the next talk for today. Dr. Bhuvan Chugh would be talking on sequencing therapy in ER positive, HER2 negative metastatic breast cancer. I would request Dr. Bhuvan to stick to timings.
Good afternoon, everyone, and I think good morning, everyone, and thank you, Dr. Nikhil and organizers for this invitation. I'm going to be talking about how do you treat a metastatic hormone-positive disease and what is the impact of the molecules in that. So if we understand well, in our clinic, this is the general scheme for a hormone-positive metastatic breast cancer. There is an onset and then there is a recurrence. And we generally go on treating them with the endocrine therapy with CDK inhibitors, and then you move on to the next phases of endocrine therapy. And when the patient becomes a ET refractory, you move on to the chemotherapy part to it, and there are multiple agents there. So this is what the spectrum we're going to be talking about today. Now moving forward, a hormone-positive disease, it's a variable disease. It's a spectrum of disease. It's not a single disease. There is a highly sensitive and a likely sensitive cohort, which, let's say, a possible patient who recurred 15 years after completing adjuvant therapy versus somebody who recurred 3.5 years after completing adjuvant therapy, you'll probably bracket them as a likely sensitive disease. There are those who are secondary resistant. They are the one who had a short DFI after completing the adjuvant therapy, let's say 6 months. And then those are the primary resistant ones, which have progressed while on being on endocrine therapy, let's say 1.5 years on endocrine therapy. And then there are those who are likely insensitive. As per the definition of the EBC, which is the most recent definition of endocrine resistance as of now, the endocrine insensitive is somebody who has recurred within 2 months of it, but we broadly get these guidelines. Now moving to the first part, when the patient presents to us for the first time, we generally have a consensus based on the Paloma 2, Monalisa 2 and Monarch 3 that ET plus CDK is a fairly good first line combination which we'll use. Somebody brought up Sonia trial. I think it's a fair trial. It's an investigator initiated study. I think the problem is we investigators are lacking far behind the pharma. By the time we are able to complete an investigator initiated study, there's another thing which comes in. Yes, it did show that there was a survival or there was no impact on the overall survival. But then we dig down into the molecular heterogeneity of it. That's where the real fine grains tend to come out. There has been a Parsifal long study. The Parsifal long study was presented this time, and it showed that the partner endocrine therapy doesn't make a difference. Whether you choose a letrozole or a fulvestrant, the CDK works better in both of them. Having said that, they did divide CDKs between the response to CDK between a year and less than a year. There is a significant improved survival in somebody who has had a response to CDK for more than a year than somebody less than a year. Now, next question which we ask ourselves in the clinic is, do CDKs work in everybody? That's what we do. And we had a 83-year-old female, we gave her an NAHT. She had an N3 plus disease. We resected her out. She continued to have N3 disease, and we did a genomic profile to understand what was causing her disease there. Her disease was being driven by PIK3s. So the question which naturally comes to us is, do all PIK3 or does PIK3 impact the response to CDKs? And I think that's what Monarchy investigators did. They read through the entire Monarchy trial. The genomic profile of the Monarchy was somewhat similar to what a breast cancer profile would be. There were PIK3s, TP53, there was a cyclin D, there was a zinc finger, there was a MYC, there's a FGFR. So all of these were there. What they found was CDK worked well in all of these subsets, other than the MYC subset. There's a comprehensive or there's a homogeneous response to what CDK does in a patient who's been given CDK in the first line. In the metastatic setting, there was subset data by the Monarch 2 and the Paloma 3, which did say that if you have a PIK3, your single-agent endocrine doesn't work well, but the advantage of CDK is it's there. There is an equal advantage of CDK, and there is an improvement of PFS from 5 months to almost 2 years when you add a CDK to it. So it does work in a PIK3 mutated cancers also. Now, what about the patients who are endocrine resistant, be it be primary or secondary, and then can you do something better to them? And that's what INAVO 120 study did. It was read out in SABCS as a last minute entry. They did a triplet therapy of inavolisib with palbociclib and fulvestrant. as Roche tells me that they're going to bring this study, they're going to bring this drug to India. What they found was in this subset of patients who are endocrine resistant, there was an impact of adding a third agent there. So you add a PIK3 inhibitor upfront, you are able to overcome the endocrine resistance which you expect there to be. Again, it was a good improvement in progression-free survival and as well as overall survival. However, I think they should be taken with a pinch of salt. It's a fairly recent study. I think the PADA study, which kind of showed us that you should be picking up the ESRs early. We are not there as yet, primarily because in our clinical practice, we do not have a oral SERD as yet. Once we have it, we probably will be able to do it in a much more comprehensive manner. Plus, there is no survival data as yet. The moment you try to switch to a oral SERD early or a fulvestrant early, when you pick up a ESR1, does it impact your survival is not there out yet. So the take-home message from the first line is endocrine therapy plus CDK inhibitor is a standard first line. It works fairly when across the heterogeneous molecular groups. Aggressive disease subtype may respond to a triplet therapy. Now, how do you move forward? Once you have progressed on a first-line endocrine therapy, where do you go? Is a single-agent fulvestrant or a single-agent endocrine therapy enough? And we have enough data by Serena, Capitello, Maintain and Emerald who show that once you add a single-agent endocrine as a second agent, you will not get anything more than 3 months. And that's where the role of genomics comes in, and that's where most of our clinical practice, we end up sending a genomic sample. Why? Because these are the mutations which are there. You come across a BRCA, you can come across multiple mutations in the PIK3 pathway. There's a ESR1 mutation. Mind you, the ESR1 and a PIK3 are not mutually coexistent. They can coexist together. There are no mutations dependent. There are tumor agnostic markers, which we'll go through in a brief right now. So let's pick up the germline BRCA first. It is fairly proven now, patients who have a germline mutation, they respond poorly to CDK inhibitors. Just be aware, somebody who has a BRCA2 is a hormone positive, you may not expect a similar response what you would expect for somebody who doesn't have a BRCA. Can you give them olaparib? So the Olympiad study was fairly, it kind of didn't show any response in a hormone positive disease in a patient who were hormone positive and were given olaparib. But mind you, most of them were given olaparib after the chemotherapy. In the subset of patients who were given olaparib before the chemotherapy, there was a PFS of around 8 months. So if you wish to use olaparib, which by the way, by the single arm trials such as Lucy, has shown that will give you 8 months, use it before chemotherapy, and it's a fairly good agent there. Coming to the PIK3 part, we understand it's a central pathway for a breast cancer, especially the hormone positive and the triple negatives. In our development, we have obviously improved the agents as we got along. There have been selective agents, and then there have been selective agent plus a degrader. So that's which has led to it, that the drug profile, the adverse effect profile of these patients have gotten much better. And then we have had an AKT inhibitor now, and it has taken 36 years into developing. The first time AKT was reported was in 1987, and we've been able to develop an agent in 2023, which has been published, and it has taken that long to get that single agent there. There was a Capitello trial which was there. I think you're all aware of it. It's trial which I don't want to go into the design of it because of the shortage of time. But what was interesting was it was similarly 40% or 43% had AKT pathway alteration. 5% had AKT and PTEN mutations per se. Otherwise, majority were PIK3CA inhibitors, PIK3 mutations. There has been improvement in the PFS, 7.3 months versus 3.1 months. However, if you dig deeper, what you realize is patients who had a prior exposure to CDK inhibitor had a PFS around 5.5 months as compared to somebody who did not have a prior exposure to CDK, in which the PFS was around 10 months. So it gives you the ballpark of 5.5-6 months once you've had a prior CDK exposure, which all of us, our patients, would have had in today's scenario. This is based on the phase 2 trial of Facketon. The Capitello is basically based on the Facketon. And this has led to a FDA approval of capivasertib in a second line once you have exposed the patient to a first line therapy, and almost 63% patients were exposed to CDK in the first line. We have the option of alpelisib. We are all well aware of SOLAR trial, but I think the caveat of SOLAR trial was that there were no previous CDK inhibitors there. And hence, the BELIEVE trial, which was presented as a poster, the final overall survival was presented as ASCO. It had 3 arms, cohort A, B, and C. A was AI plus CDK, B was fulvestrant plus CDK and prior exposure, and third was with a chemotherapy arm. It has again showed you a similar study that once you expose a patient to ET plus CDK and then you move on to another ET plus alpelisib, it will give you a ballpark of around 5.5, 6 months. And that's where the PFS stands. So as a second part take home, BRCA mutations have poor response to AICDK. PARP inhibitors are an option, should be given before chemotherapy. PIK3 inhibitors and AKT inhibitors are both valid options for PIK3 mutated, irrespective of the prior CDK exposure. AKT inhibitors are an added modality for a AKT mutated as well as a PTEN mutated. Coming to the next part of it, what is ESR1 study does to you? So Emerald, the good part about Emerald was almost all of the patients had an exposure to CDK in the past. This had shown that if you bring in just the entire ITT population, the PFS was around 2.5 months or around 3 months. And if you look at the ESR1 mutation, it was around 4 months. However, if you split the entire thing apart, patients who had a good response to CDK inhibitor, let's say, rather somebody who's had a more than a year response to CDK inhibitor, the PFS was around 8.6 months. And that's the reason the Parsifal long trialists, they went back and they divided their entire cohort into less than a year and more than a year. And what they've been able to tell us is patients who have had a good response to CDK in the first line will respond even favorably to a single agent SERD, oral SERD in a second line. And that's what that study did to us. But there is a bit more to it. There is a sharp decline in the survival curves as you look at it. The sharp decline are the patients who are endocrine resistant. We do not know the mechanisms of it as yet. There is a later separation of curves which does show that patients, when they have declined and the endocrine resistant patients have fallen off the treatment, there is a set of patients who respond favorably to oral SERDs. And our duty as an oncologist is to figure out those patients and dig deep there. What lies there is what making it go. For a patient who has ESR1 AKT mutation, we had one of the patients in our clinic. We possibly were divided. How do you treat it? Do you give her a Capitolo or you do a Emerald for her? She's a resident of Dubai. She'll have an access to capivasertib before she can have access to elacestrant. But then yes, I, in my knowledge, today would treat her with elacestrant rather than Capitolo, possibly because she had a year of response to CDK inhibitor. Now, what is the impact of NF1 on CDK inhibitors? So NF1, neurofibrinogen 1, which we thought was pretty uncommon till now, is found in almost 20% of hormone positive patients. There is the divided data. The world is not heated yet. If you look at the biologics of it, a decreased NF1 should lead to increased RAS activity and upregulation of the PIK3 and the MAP kinase pathway, which in a logical sense, sorry, the slide is corrupted, which in a logical sense should give you a better response to CDK inhibitor. And these patients should respond favorably to CDK inhibitors. But in the same conference, there's a data which was presented that patients who were NF1 wild type had a better response to AICDK as compared to NF1 mutated. So we are not there as yet. The NF1 is still in the realms of doubt, whether should we be considering this as a pro or an anti to CDKs. So take home is subset of ESR1, including those with a CDK more than 12 months of exposure to CDK, have an option of oral SERD. NF1 mutated, hormone positive, almost in the range of 20%, they have a debatable response to CDK. What if you do not have anything? Well, we have the Maintain and the PACE and the Palmyra there. You can choose to continue with the single agent CDK. You have the Bolero and the 0102 study in which you can add everolimus there. So for a patient who do not have a mutation, an mTOR and a continuing CDK is still an option. Moving forward to the last part, which I'll try to go through it. I understand the time is short. There is something called as apobec signature. There is a rapid conversion, or there is increased convergence of C to G and C to T. There is a subset of hormone positive patients. When you do a genomic profile of them, you will find a high TMB. This high TMB is an apobec signature. Go back to it. In this particular case, we went back to Foundation and asked them whether the patient had an apobec signature or not. They gave us a confirmation that the apobec signature is there. And once you have apobec signature, the immune checkpoint inhibitors become an option in such patients in which there is apobec signature. If you do not have apobec signature, if you have a HER2 low, just a second, you can have TDXT as a part of DB04 trial. There was this paper which was read out at ASCO 23 in which once you do a repeated biopsies, a HER2 zero gets converted to HER2 low almost in 33% of the patients. And that's where the role of a repeated biopsy comes in. If you do not have that, a TROPiCS-02 with a Trodelvy or a sacituzumab govitecan does show you a PFS of around 5.5-6 months. Similarly, there is a Tropion-01 trial which was presented this year at SABCS again. It had shown you a PFS of around 6.5-7 months. This was irrespective of the CDK inhibitor. So an HER2, Trodelvy or a Dato-DXd are an options once you are running out of the options of endocrine therapy then. So my last take home is ADC, HER2 low or a TROP2 are further options and one can also look for a tumor agnostic markers as you go along there. That'll be my time. Thank you.